Welcome back to the deep dive. Today, we're embarking on an extraordinary journey, really deep into the core of our being. We're doing a deep dive into the anatomical and physiological marvels that expertly protect our vital organs. Have you ever truly considered what lies beneath the surface of your abdomen, keeping everything, in its place and functioning flawlessly? It's far more intricate, dynamic, and frankly more fascinating than you might imagine. Our mission today is to take a stack of highly detailed sources, specifically a renowned surgical textbook, and unpack the critical insights about the abdominal wall, omentum, mesentery, and retroperitoneum. Think of this as your shortcut to truly understanding these foundational areas, getting to a level of mastery akin to elite professionals in the field, complete with surprising facts and crucial clinical relevance. We're going to go deep on every concept, making sure you grasp not just the what, but the profound why behind these incredible structures.
Yeah. And what's truly fascinating here is how incredibly interconnected these regions are. Understanding them is absolutely critical, not just for surgeons, obviously, but really for anyone who wants to grasp the sophisticated mechanics of the human body. We'll explore everything from how these structures form during embryonic development, all the way to the common acquired conditions that can challenge their integrity. We want to provide those aha moments that connect the textbook knowledge directly to real-world implications for you.
Okay, let's unpack this first part then, the abdominal wall. It's often thought of as just, skin and muscle, but it's so much more. A dynamic, multi-layered shield. Why is understanding its intricate anatomy so absolutely critical in patient care, especially, as you said, for surgeons?
Right. If we connect this to the bigger picture, it's all about fundamental support and protection. Imagine your body as a carefully engineered fortress. The abdominal wall forms the front-facing, flexible part of that fortress. It's precisely defined at the top by your ribs, specifically the costal margin, and that pointy xiphoid process at the bottom of your sternum. And at the bottom, it extends down over the pubic bones of your pelvis. This vital structure acts as a robust yet flexible shield. It safeguards both the organs housed within the peritoneal cavity, that's your main abdominal space, and those tucked behind it in the retroperitoneal space. Its integrity is absolutely fundamental for normal bodily function. It enables everything from simple movement like bending and twisting to complex internal processes like breathing, coughing, even childbirth. For anyone in medicine, and especially for surgeons needing to access the abdomen, a thorough understanding of its layers is paramount. For safety, for efficacy, it dictates where you cut, and crucially, how you put it back together.
Okay, here's where it gets really interesting for me. How does something so complex with all these distinct layers even begin to form? What's the origin story?
Ah, the embryology. It's a masterpiece, truly. The abdominal wall primarily springs from the mesoderm, which is one of the three primary germ layers, basically the foundational building blocks of an early embryo. It starts as bilateral migrating layers. Think of sheets of cells moving from two sides. They originate from the paravertebral area, the region alongside what will become your backbone. These layers progressively extend and ultimately envelop what will become the future abdominal contents.
And there are specific milestones in this.
Yes, key milestones. The leading bars of these migrating layers, their advancing edges, begin to fuse right in the midline. This fusion forms a crucial structure called the linea alba, which is Latin for white line. Think of it as a central seam running down the front of your abdomen. This fusion is well underway by about 7 weeks after gestation.
7 weeks, okay.
And it reaches all the way down to the umbilicus, your belly button, by approximately 8 weeks. This precise and complex fusion process during development is absolutely crucial for understanding why certain congenital defects problems present at birth can occur if this process doesn't go exactly as planned. It's a marvel of biological engineering, and sometimes, a slight misstep has lifelong implications.
So when we talk about layers, how many are we really talking about? 9, you mentioned. And what's special, or maybe surprising, about each one?
That raises a fantastic question. When a surgeon makes an incision, what exactly are they going through? It's not just a simple cut. There are indeed 9 distinct layers making up the abdominal wall, each with its own unique properties and functional importance. Understanding these is key to appreciating its protective capabilities and how surgery must interact with it.
Okay, walk us through them, layer by layer.
All right. First, the most superficial layers, the outermost defenses. Layer 1, obviously, is your skin. Directly beneath that is the subcutaneous tissue, mainly superficial adipose tissue, the fat layer just under your skin. This layer is continuous with a deeper fibrous layer called Camper's fascia. Deeper still, we find the superficial fascia, specifically scarpa's fascia. Now, this isn't just loose tissue. It's a dense fibrous matrix. It fuses with the anterior fascia of the flank and the back. This fibrous nature is critical, providing structural integrity, holding things together, almost like a strong internal netting.
Got it. Skin, fat, fibrous netting. What's next? The muscles.
Exactly. Moving inward, we hit the muscular core, the real powerhouses. Immediately, right down the middle, we have the rectus abdominis muscles. These are the paired longitudinal muscles running the length of your abdomen, divided by that linea alba. These are your six-pack muscles. They originate down at the pubic symphysis and crest and insert way up on the xiphoid process and lower ribs.
And they have those bands across them.
Yes, the tendinous insertions. Typically, 3 of them cross the rectus muscle along its length, giving that segmented appearance. And importantly, each rectus muscle is contained within an aponeurotic sheath, a strong, fibrous envelope formed from the fusion of layers from the side muscles.
Okay, so those are the central muscles. What about the ones on the sides, the obliques?
Right, the lateral obliques. There are 3 distinct layers here. Their fibers are ingeniously oriented obliquely at an angle relative to each other. This creates an incredibly strong, multi-directional support system, great for twisting and bending. The most superficial is the external oblique. Its fibers travel downward and toward the midline. Think putting your hands in your pockets. Beneath that lies the internal oblique, with fibers running upward and toward the front, almost perpendicular to the external. And the deepest of these 3 is the transversus abdominis. Its fibers run horizontally like a natural corset. It helps compress abdominal contents and stabilize your core. Really a marvel of biomechanical engineering.
So these muscles combine to form that rectus sheath you mentioned, but I hear it's not uniform. What's this arcuate line and why is it so important? Sounds like a key detail.
It absolutely is. This is one of the most critical anatomical distinctions for surgeons, and a perfect example of how subtle anatomical variations have huge clinical implications. The rectus sheath, enclosing the rectus muscles, does have a differing composition above and below a specific landmark, the arcuate line. Think of it as an invisible, slightly curved line running across the lower abdomen, a sort of dividing line.
Okay, so what's the difference above and below?
Right, above the arcuate line. In this upper region, the rectus muscle is well supported front and back. The strong anterior rectus sheath is formed by the aponeurosis, that flat tendon sheet of the external oblique and part of the internal oblique aponeurosis. And the posterior rectus sheath, providing support from behind, is formed by the rest of the internal oblique aponeurosis plus the transversus abdominis aponeurosis. So above the line is robustly encased, strong wall on both sides.
Makes sense. And below.
Now, below the arcuate line, this is where it changes dramatically, and it's crucial. In this lower region, all the aponeurotic layers of the lateral muscles, external oblique, internal oblique, and transversus abdominis converge and form only the anterior rectus sheath.
So what's behind the muscle then?
That's the key. It leaves the lower part of the rectus muscles with only the transversalis fascia as a posterior fascial covering. And the transversalis fascia, while it's there, is a relatively weak fibrous layer. It's separated from the peritoneum, the inner lining, by just some preperitoneal fat.
Weak spot, then.
Exactly. The implication is significant. This structural weakness below the arcuate line directly impacts surgical repairs and makes this area much more prone to certain types of hernias. Understanding this specific weakness is key to understanding why, for example, Spigelian hernias, though rare, occur precisely in this vulnerable zone. It's like a natural weak point in the design.
That's a fantastic explanation. It really highlights the importance of knowing the precise anatomy. What are the very innermost layers then?
Almost there. Just inside that muscular wall and the transversalis fascia is the preperitoneal adipose tissue, a layer of fat. And then the very last layer, the inner lining itself, the peritoneum. It's a thin, slippery membrane lining the cavity and covering most organs, letting them glide smoothly.
And you mentioned folds on the inside related to development.
Yes, exactly. Along the deepest part, the posterior abdominal wall, we find important folds that correspond to underlying blood vessels and fascinating embryological remnants, significant landmarks, especially for laparoscopy. The median umbilical fold is formed by the obliterated urachus, that fibrous cord that once connected the bladder to the belly button in the fetus.
Bladder to belly button, wow.
Yeah. Then there are the bilateral medial folds, formed by the remnants of the umbilical arteries, vital fetal vessels. And lastly, the lateral folds. These are associated with the inferior epigastric vessels. These are active blood vessels. And knowing their location is crucial for surgeons to avoid injury during laparoscopic entry. fetal remnants, leaving vital clues for adult surgery.
Incredible detail. So this complex structure, how does it get its blood supply, its energy, and how is it connected to our nervous system? What are its lifelines?
It has a rich and really strategically designed blood supply and innervation. The deep blood supply primarily comes from two major arteries, the inferior and superior epigastric arteries.
Oh.
The superior epigastric artery is the final branch of the internal thoracic artery coming down from the chest. It enters the rectus sheath just below the ribs. It travels along the back of the anterior rectus sheath. And here's the clever part. It forms a crucial anastomosis, a connection, like a bypass with the inferior epigastric artery, usually around the belly button.
A backup system.
Essentially, yes. The inferior epigastric artery arises from the external iliac artery down in the pelvis. Together, this connection provides significant collateral circulation between the upper and lower body vasculature. If there's blockage, blood might reroute. The wall also gets supply from branches of subcostal arteries under the ribs and lumbar arteries from the lower back.
What about the more superficial parts, skin and fat?
The superficial blood supply comes from branches of superficial epigastric, femoral, superficial external pudendal, and superficial circumflex arteries. Venous drainage generally follows the arteries.
And lymphatics, how does fluid drain?
The lymphatic drainage is organized too, which is important for infection or cancer spread. Above the umbilicus, lymph generally drains to the superficial axillary nodes in your armpit. Below the umbilicus, it goes to the inguinal nodes in your groin. Near the umbilicus itself, there's an interesting path along the falciform ligament towards hepatic nodes in the liver.
And nerves, for feeling and movement.
Innervation is segmental. Specific spinal cord segments supply specific areas, leading to a predictable dermatomal sensory pattern. So sensory input, feeling, comes from nerve roots T4 down to L1, and motor control for the muscles comes from spinal nerves T6 to T12. This precise setup allows for both voluntary movement and vital feedback.
So beyond just holding everything in and protecting, what else does the abdominal wall do for us, its active roles?
Great question. What are the functional implications? These muscles are highly dynamic, assisting with loads of vital functions. First, torso movement. Working with back and trunk muscles, they help with flexion, extension, rotation. Trunk flexion, bending forward or sideways, uses the rectus muscles and the obliques. Torso rotation is more complex. To twist right, for instance, you use your left external oblique and your right internal oblique working together. It's beautifully coordinated.
The diagonal pull.
Exactly. And crucially, these muscles powerfully raise intra-abdominal pressure. This helps with so many things. Respiration, especially forced exhalation, essential for coughing and sneezing, providing that explosive force. They also significantly assist with defecation and urination, increasing pressure. And of course, in females, they're indispensable during parturition, childbirth, aiding expulsive efforts. So yeah, a multifunctional dynamic unit working constantly.
Given all this intricate anatomy, how do surgeons actually get into the abdomen safely, and what are the key considerations for closing it back up? The art of access and closure.
Knowledge of this anatomy is absolutely paramount for safe entry. The goal is always adequate exposure with minimal functional disruption, a delicate balance.
Right.
Incisions for open surgery are generally chosen based on proximity to the target. Two main types, longitudinal, up and down, or transverse oblique, across or angled. Interestingly, studies haven't shown clear superiority overall in complications or recovery between the types, though some evidence suggests transverse incisions might have lower hernia rates, but potentially higher wound infection rates sometimes. It's often surgeon-dependent.
Makes sense.
And surgeons use retractor systems tools like the Bookwalter or OmniTrack to gently hold the incision open for better visibility.
What about the specific types, like the common midline one?
Yeah, the midline incision is the most common longitudinal one. Great access to most organs, even some retroperitoneal stuff. It goes right down the linea alba, minimizing injury to muscles, nerves, vessels. That's a big plus. Closure requires carefully reapproximating that midline fascia. Classically, sutures are 1 centimeter from the edge, 1 centimeter apart. But interestingly, 2 big European trials found reduced hernia rates with shorter stitch widths, like 5 to 8 millimeters. Precision matters. Studies are ongoing in the U.S. on this.
Wow. Even stitch spacing is debated.
Oh, absolutely. And there's research into using prophylactic mesh during closure to prevent hernias. Shows short-term benefit, but long-term data on complications, and the best mesh type or placement is still needed. Less common are perimedian longitudinal incisions lateral to the midline. They restrict access and risk more damage, so not used as often.
What about the transverse or oblique ones?
With transverse oblique incisions, surgeons can either divide muscle fibers or, ideally, gently separate them. A classic is the McBurney's incision. an oblique muscle-splitting approach, historically for appendectomy, located about a third of the way from the hip bone to the belly button. Subcostal incisions under the ribs are for the upper abdomen, liver, gallbladder, spleen, etc. Closing these needs 2 layers: deep, internal oblique, transversus abdominis, transversal of fascia, and superficial, anterior rectus sheath medially, external musculoponeurosis laterally.
Complex closure.
It is. For even wider access up top, you can do a bilateral subcostal chevron incision, looks like an inverted V, or add a midline cut superiorly to that chevron, the Mercedes-Benz modification for huge upper abdomen, lower chest access. And then there's the Phanesil incision, very common for pelvic procedures like C-sections. That's a transverse skin cut, transverse sheath cut, dissecting it off the muscles, separating the rectus muscles vertically, and the vertical access through the deeper layers. Closure involves peritoneum, muscles, and the anterior sheath.
So, how does minimally invasive surgery, like laparoscopy, change the game for incisions? Seems simpler, but is it?
It's definitely an evolution, bringing its own challenges. With laparoscopy, port site placement needs careful planning angles, working distances, all crucial.
Okay.
Before entry, safety steps like a nasogastric tube to decompress the stomach or a Foley catheter for the bladder reduce injury risk, minimizing the unexpected. For initial entry, 2 main techniques: the open Hasson technique, direct visualization, systematically opening each layer. Some reviews suggest maybe lower complications. The other is the closed Ver's needle technique. Controlled access with a specialized needle, confirmed by tests like saline drop or pressure check, then gas insufflation starts.
Which is better?
The controversy. Choice is often surgeon preference. Randomized trials, though small, haven't shown significant differences in major complications. Both can be safe and effective when done skillfully.
Got it. But no surgery is risk-free. What are the common challenges after any abdominal incision?
You're absolutely right. Minimizing incision length is key to reducing morbidity, the complication rate. Complications can include local issues like hematomas, blood collections, or seromas, fluid collections. Surgical site infections are always a risk. More serious structural issues are fascial dehiscence, the wound bursting open at the fascial layer, and incisional hernias, a big topic we'll dive into, where contents bulge through the scar. Lastly, nerve injuries can happen, causing pain, numbness, or weakness.
Fascinating how precise the formation is. But what happens when that complex development doesn't go exactly right from the start? Issues present at birth.
Right. When embryological development deviates, we see distinct congenital abnormalities. Remember those folds converging at the umbilicus around 8 weeks and the temporary herniation around 6 weeks? Failures here lead to problems. 2 notable ones are omphalocele and gastroschisis. An omphalocele happens when the midgut fails to return to the abdomen, which normally occurs by 12 weeks. The contents protrude through an open umbilicus, but crucially, they're covered by a protective membrane sac. Gastroschisis, however, results from a defect in the abdominal wall itself, maybe genetic or vascular. Here, viscera protrude lateral to the umbilicus, usually the right side, and critically, without a covering sac. Exposed.
Covered versus uncovered makes a big difference, I imagine.
Huge difference in management. Another set involves vitelline duct anomalies. This duct connects the embryonic midgut to the yolk sac, normally vanishing around 8 to 9 weeks if it doesn't regress properly. A spectrum. Total persistence gives an omphallomesenteric fistula. Intestinal contents can drain at the belly button. Partial closure might form an omphallomesenteric cyst. A common remnant is a Meckel's diverticulum, a pouch on the ileum, often mimicking appendicitis. Or it could persist as a fibrous band attaching intestine to the wall, risking bowel obstruction. These generally need surgical resection if found.
And the urachus.
Schwartz anomalies. The urachus connects the bladder to the umbilicus during development, normally becoming the median umbilical ligament. Failure to close can result in a urinary fistula, urine leak at umbilicus, or a urachal cyst. Treatment is excision and closing any bladder defect. Small developmental steps, big potential consequences.
Beyond birth, the wall can still face challenges. What common issues develop later in life?
Right. What causes weaknesses or disruptions over time? The wall, despite its strength, can develop acquired issues, often from increased pressure, weakening layers, or past injuries.
Like hernias.
Exactly.
Right.
Abdominal wall hernias are very common. A hernia is just a protrusion or bulge of abdominal contents fat, intestine through a defect or weak spot in the muscle or fascia. While some are congenital, most are acquired weakening, disruption, failed surgical healing. They might present as just a bulge, worse when you bear down, valsalva, or cause significant discomfort.
How are they diagnosed?
Usually physical exam, standing and lying down, They might be reducible, pushed back in, but if it gets incarcerated, it can't be reduced. That usually needs surgery because the contents are trapped. If intestine is trapped, it can cause bowel obstruction and emergency with pain, nausea, vomiting.
And worse is strangulation.
That's the critical danger. Strangulated hernia. Blood supply to the contents is cut off. Leads to ischemia, tissue death, infarction, potentially perforation, life-threatening. That's the big worry.
Let's talk specific types, non-incisional ones first.
Okay. Non-incisional hernias are named by location. Epigastric hernias are defects between the umbilicus and xiphoid process, often small, maybe multiple, caused by muscle weakness, weak fascia, increased pressure. They rarely contain bowel, usually just omentum or falciform ligament fat. Since incarceration is rare, repair is usually only for symptomatic patients. Small open incision suture closure often works. Laparoscopic is an option too.
What about belly button hernias? Umbilical?
Umbilical hernias can be congenital or acquired. In newborns, very common, especially preemies. The umbilical opening didn't fully close, but most close on their own by age 5 as muscles grow, so often just monitored. Repair in newborns is needed for incarceration symptoms or if it doesn't close by age 5.
And in adults?
In adults, usually acquired from increased abdominal pressure, pregnancy, obesity, ascites, fluid buildup, more common in females. Small asymptomatic ones might be watched, but if it enlarges, causes symptoms, or gets incarcerated, surgery is needed, open or laparoscopic. For large defects where edges won't meet without tension, mesh is used, ideally placed in sublay below the fascia, between muscle and lining, and sutured to prevent movement.
You mentioned ascites. What about patients with cirrhosis and ascites? That sounds tricky.
It's a major clinical dilemma. High pressure from uncontrolled ascites makes these hernias huge. Plus, severe liver disease means high operative risk. The hernias often contain ascites fluid, omentum, sometimes bowel. Risk of skin breakdown over the hernia, rupture, weakening fluid, and dangerous spontaneous bacterial peritonitis infection.
So how do you manage that?
Critical strategy. Control the ascites before any repair attempt. Asymptomatic. Conservative approach plus aggressive ascites management. Liver transplant candidates. Usually repair at the time of transplant. Pre-transplant repair is too risky. But emergent surgery is needed if it's incarcerated or the skin is thinning or ruptured. High stakes.
What about Spigelian hernias along that arcuate line?
Spigelian hernias. Rare. Occur along the arcuate line. Remember that weak spot below the line? That's where they form. Peritoneum pokes through laterally. Often present with pain and swelling in the mid to lower abdomen. Key feature. High incarceration rate, maybe up to 20%. More dangerous.
So repair is usually recommended?
Almost always, due to that high incarceration risk. Open or laparoscopic. The defect is closed by approximating the transversalis fascia edges to the rectus sheath, reinforcing the weak spot.
Now, incisional hernias, a common surgical challenge, you said.
Very common. Incisional hernias develop at previous incision sites. Any cut can weaken the wall. Up to 20% of midline incisions develop one eventually.
Are some incisions riskier?
Yes. Vertical incisions generally higher risk than transverse oblique. Upper abdominal incisions higher risk than lower. Even laparoscopic port sites can herniate.
What causes them? Complex.
Very complex etiology. Combination of patient factors, diabetes, immunosuppression, obesity, smoking, malnutrition, connective tissue disorders, and local operative factors. Surgical technique, wound infection, high tension at closure. They can develop years later, up to 10 years, but usually show up early post-op. Presentation can be asymptomatic bulges or severe discomfort. Multiple hernias can occur along one scar. Elective surgery for symptomatic patients. Small defects actually have higher incarceration risk, so they should be repaired. Optimizing patient factors like smoking and obesity before repair is crucial.
How are they managed surgically? Tissue versus mesh?
Two main approaches. Historically, simple suture repair, sewing edges together, was used. But recurrence rates are very high, up to 54%. This led to widespread use of mesh repair, now the standard for elective incisional hernias. A major Cochrane review showed mesh significantly reduces recurrence, like 16% with mesh versus 33% with simple repair. Big difference.
But downsides to mesh?
Yes, slightly higher mesh infection rates. A trade-off to consider.
What about large defects? Too much tension to just suture?
Right. For that, surgeons might use the component separation technique described by Ramirez back in 1990. The goal is to reduce tension. It involves creating musculofascial advancement flaps by strategically dividing parts of the external oblique aponeuroses. You can also incise the posterior rectus sheath. These maneuvers allow the rectus muscles to mobilize medially, sometimes up to 10 centimeters, allowing tensionless midline closure.
Has that technique evolved?
Yes. Early versions had high infection rates due to large skin flaps. Newer techniques minimize flap creation and infection. Endoscopic component separation further reduces ischemia and infection risk. Component separation without mesh has recurrence rates comparable to standard mesh repair, but avoids mesh risks. With mesh added, recurrence might be as low as 4–10%. It's a clever use of the body's own tissues.
Where exactly is the mesh placed? Sounds like there are options.
Yes, mesh placement is debated. Options include overlay above the fascia, interlay bridged across defects, sublay underneath fascia between rectus muscle and posterior sheath, or underlay inside the abdomen against peritoneum. A systematic review suggested sublay placement might reduce recurrence and wound issues. In that technique, the mesh goes in the plane between muscle and posterior sheath, and the anterior sheath is closed over it if possible without tension.
And the mesh itself, what's it made of? Seems like a science in itself.
It really is material science. Broadly, synthetic and biologic. Synthetic meshes can be permanent or degradable. Permanent synthetics, polypropylene, polyester, EPTFE, are durable, low cost. Degradable synthetics, like fickle mesh, get absorbed, lose support over time. High recurrence, but lower infection risk, so useful temporarily in contaminated fields where permanent mesh is too risky. Newer synthetic biomaterials, GOR BioA, Phasix, degrade slower, may reduce recurrence, but long-term effectiveness is still TBD.
What about biologic meshes?
Biologic meshes are different. Decellularized, collagen-rich tissue from porcine, bovine, or human sources, they allow host cells to grow in, eventually replacing the mesh with host tissue. High cost. Can be used in infected fields. Efficacy in preventing recurrence is still unclear compared to synthetics. Then there are composite products. 2 components for placing inside the abdomen. One side integrates with the abdominal wall, non-degradable synthetic. The other side facing the organs is covered, synthetic biologic, to prevent adhesions, erosion, fistulas. Using materials like polyclactin, collagen, cellulose, titanium, omega-3s, incredible tech.
Does the mesh design matter? Pore size, weight?
Yes, mesh design is important. Large pore, lightweight mesh was thought to delay incorporation, but that's not really seen. Theoretical advantages, better host tissue incorporation, more elasticity, maybe less pain than older, heavier meshes. Initial data suggest maybe lower infection rates with large pore mesh too.
Laparoscopic versus open repair for these, what's the balance?
A balancing act indeed. Laparoscopic repair, described back in '93, is now accepted. Advantages shown for laparoscopic: lower incidence of surgical site and mesh infections, faster recovery, less post-op pain compared to open. Meta-analyses found similar recurrence rates, but confirmed lower wound issues with laparoscopic.
Downsides to laparoscopic.
Higher risk of bowel injury during the procedure. That's a significant consideration. Also, follow-up in many studies is relatively short. More long-term data is needed for a definitive comparison.
How is the laparoscopic repair actually done?
Specific port placement needed. Lateral ports for midline defects, contralateral for lateral ones. Adhesions between wall and bowel must be meticulously taken down. Hernia contents reduced. Sac usually left behind. Mesh is shaped to cover the defect with good overlap, 4 to 5 centimeters. Secured with transfascial sutures, circumferentially, maybe spiral tacks too.
What about robots?
Robotic surgery is emerging. Theoretical pluses, better visualization, articulating instruments, might improve outcomes. Cost effectiveness is unclear, more studies needed.
And laparoscopic surgery itself can cause hernias, port site hernias.
Yes, a modern challenge. Laparoscopic port site hernias. Incidence is low, less than 1% in meta-analyses, but increasing as we do more laparoscopy. Risk is substantial bowel strangulation ischemia because the defect is often small and tight. Commonly present as a Richter's hernia, only part of the bowel wall herniates. Sneaky, might not cause full obstruction, can show up early or years later. Risk factors similar to other incisional hernias. Most common site is the umbilicus, but can be anywhere. Usually 5mm ports in adults, any size in kids. Repair is typically open. Enlarge the skin incision, reduce the hernia, close all fascial layers carefully.
That's a thorough look at hernias, but I've heard of rectus abdominis diastasis. Sounds like a hernia, but isn't. Key difference.
Crucial distinction. Rectus abdominis diastasis, or diastasis recti, is often confused with a hernia, but it's fundamentally different. It's an anatomical term for abnormal separation of the rectus muscles and laxity, or looseness, at the linea alba. The key difference: the midline fascia remains intact, no actual hole. This means no true herniation of contents, and therefore no risk of incarceration or strangulation. It's stretching and separation, not a defect.
Got it. No hole, no strangulation risk. What causes it?
Can be congenital or acquired. Acquired risk factors usually involve increased intra-abdominal pressure, obesity, and very commonly pregnancy due to the expanding uterus. Also things that weaken the wall: connective tissue disorders, prior surgery, postpartum risk factors. Older age of pregnancy, multiple pregnancies, recurrent C-sections, postpartum exercise actually reduces the risk.
How's it diagnosed?
Often physical exam. A fusiform bulge along the midline, worse when tensing the muscles or bearing down. Ultrasound can confirm and rule out a true hernia. CT can also confirm and measure the separation distance, usually 2 centimeters considered diastasis, though that's debated.
Does it need surgery?
Unlike a true hernia, diastasis does not require surgical repair for health reasons. No strangulation risk. It might improve with weight loss and specific exercises. Surgery is considered mainly for functional disability or cosmetic reasons. Options are open or laparoscopic application, stitching the muscles closer. Mesh can be used, but often increases complications. Unfortunately, high long-term recurrence risk, plus you introduce a new risk of incisional hernia, so it's not undertaken lightly. Aesthetics versus potential new issues.
Okay, shifting gears a bit. A hidden bleed in the abdominal wall, rectus sheath hematoma. Sounds serious. What causes it, and how do we spot it?
Yeah, it's a fascinating scenario, often mistaken for other abdominal issues. Rectus sheath hematoma results from disruption of branches of the inferior epigastric artery, usually, and failure of the bleeding to stop on its own. Vulnerable spot, often occurs around the arcuate line. Those artery branches are relatively fixed. They're vulnerable to shearing forces with sudden movements or pressure increases, like a rigid pipe breaking under stress.
What increases the risk?
Several risk factors. Direct trauma, including iatrogenic, like from a laparoscopic trocar, vigorous rectus muscle contraction, forceful coughing, sneezing, strenuous exercise, chronic pulmonary disease, coughing fits, and significantly, anticoagulation use markedly increases risk. Crucial patient history.
How does it present?
Typically acute abdominal pain and a palpable abdominal wall mass. The diagnostic challenge can easily mimic intraperitoneal issues, like appendicitis if it's on the right side. Key distinguisher. Pain usually increases with rectus muscle contraction, opposite of many internal conditions where tensing might splint and lessen pain. Another classic clue. Fothergill sign. A palpable mass that doesn't change during rectus contraction strongly suggests rectus sheath pathology.
How is it confirmed?
Ultrasound or, more definitively, a CT scan with IV contrast clearly shows the blood collection. Initial management, type and screen, check hemoglobin hematocrit for blood loss, check coagulation factors. Critical info.
And treatment depends on?
Heavily on hemodynamic stability and hematoma size. Stable, small hematoma, stable labs, normal clotting. Observation, maybe outpatient. Stable but larger bilateral hematoma or dropping hemoglobin. Hospital monitoring, serial labs, compression, bed rest. Reverse anticoagulation if needed, if in hypovolemic shock from blood loss. Aggressive resuscitation, blood products, often followed by angiographic embolization blocking the bleeding vessel via catheter. Angiography might also be needed if it's enlarging or the patient worsens. Surgical therapy is reserved if angiography fails. Evacuate the hematoma, ligate the bleeding vessels. A multi-step approach for a sneaky bleed.
Now this one sounds paradoxical. Desmoid tumors. Aggressive but doesn't spread. What's the deal?
Perfect description. It raises questions about how we define tumor behavior. Desmoid tumors or aggressive fibromatosis are fascinating. They're fibroblastic neoplasms arising from connective tissue cells. Unique behavior. Locally aggressive and infiltrative. They grow into surrounding tissues, causing local damage. However, despite this aggressive local behavior, they have no metastatic potential. They don't spread distantly like typical malignant cancers. A bully staying in its own yard, as you might say.
Where do they occur?
Anywhere, but commonly in the abdomen or abdominal wall. They're rare, usually sporadic, but notably associated with familial adenomatous polyposis, FAP, that genetic colon cancer predisposition syndrome. 10–15% of FAP patients get them, and they can become the primary cause of death after colectomy. Serious consequence. Also linked to Gardner syndrome. For sporadic cases, risk factors include previous surgery, pregnancy, hormones, trauma, higher rate in females.
Diagnosis and prognosis.
Diagnosis via core needle or incisional biopsy. Poor prognostic factors for recurrence. Larger size, younger age, extra abdominal location.
Treatment sounds complex if they're aggressive but don't metastasize. Has it evolved?
Significantly. Historically, gold standard was margin negative resection, removing it all with clean edges, plus mesh reconstruction. Newer consensus is shifting. While complete removal is ideal, a positive margin, some cells left, might not need re-resection if it causes high morbidity, especially with adjuvant therapy available. Prioritizing function.
Is surgery always needed?
Not necessarily anymore. Growing evidence supports close, watchful waiting for some, as they can stabilize or even spontaneously regress. One study, only 16% needed surgery over 3 years, and 29% regressed on their own. So the NCCN now suggests initial observation for asymptomatic, non-life-threatening ones. Surgery indications now generally reserved for symptomatic disease, risk of invading critical structures, or enlarging tumors.
What about other therapies? Radiation,
Yeah.
chemo?
Adjuvant, neoadjuvant therapy roles are still debated. Radiation might be an option for non-surgical candidates. For unresectable tumors, systemic therapy might be used. Hormones, NSAIDs, certain chemos, doxorubicin, carboplatin, targeted therapy like imatinib, a very individualized approach for these unique tumors.
That's a lot for a rare tumor. What about other, even rarer masses in the abdominal wall?
Beyond desmoids, other tumors can occur, though less commonly. Benign ones include lipomas, fatty tumors, and neurofibromas, nerve sheath tumors. Resection usually only if symptomatic or enlarging. Malignancies are exceedingly rare. They include subtypes of sarcomas, connective tissue cancers, dermatofibrosarcoma protuberans, schwannomas, melanomas.
Work up for those.
Core needle or excisional biopsy,
Yeah.
MRI or CT with contrast, MRI often preferred for detail. Chest imaging, CT for high grade, X-ray for low grade, to check for lung metastasis.
And shriek.
Surgical resection is the mainstay for non-metastatic ones. Margins needed. 1 centimeter for most sarcomas, maybe 2 centimeters for dermatofibrosarcoma protuberans. Resection of superficial tumors should include underlying fascia, often needing mesh closure to prevent laxity hernia.
Adjuvant therapy.
Efficacy, unclear due to rarity, might be recommended for large, 5 centimeters, or high-grade tumors. Some centers use neoadjuvant radiation to monitor response, chemo in certain situations. If tumors involve underlying organs, en bloc resection, removing tumor and involved organs together, might be needed. Closure options are complex. Primary prosthetic mesh, absorbable biologic mesh, even myocutaneous flap reconstruction. Complex tumor removal and reconstruction.
Okay, let's move deeper. We've covered the wall. Now the omentum. What exactly is this policeman of the abdomen?
The omentum, often called a fibrous adipose apron, is truly fascinating. More than just fat, it provides crucial support and protection to the intra-abdominal organs. Embryologically, it derives from the dorsal mesogastrium, starts forming early, around week 4, as a double layer. The spleen actually develops between these layers. Eventually, these layers fuse, the spleen finds its spot, and ligaments like the gastrosplenic, stomach to spleen, form.
And anatomically, greater and lesser.
Yes, the greater omentum is the prominent one, a large double-layered sheet of fibroadipose tissue hanging down from the stomach's greater curve, drapes over the small intestines like an apron, then folds back up to attach to the transverse colon. Key ligaments here are the gastrocolic, stomach to colon, and gastrosplenic, stomach to spleen. Blood supply comes from the right and left gastroepicloic arteries. Venous drainage parallels that into the portal system. Lymphatics go to subpyloric or splenic nodes, then celiac nodes.
And the lesser omentum.
The lesser omentum is smaller but vital. Forms the anterior boundary of the lesser sac, a pouch behind the stomach. Extends between the liver and the stomach's lesser curve. Also known as the hepatoduodenal and hepatogastric ligaments. Critically, the portal triad, common bile duct, portal vein, hepatic artery, runs within its inferolateral free edge. That free edge also forms the foramen of Winslow, the opening into the lesser sac. Surgically important for the Pringle maneuver clamping the portal triad to control liver bleeding. Clever trick.
The policeman of the abdomen, quite a title. What makes it so vital to earn that?
Right. How does this fatty apron act as such a powerful defender? Rutherford Morrison's description was apt. The greater omentum is a key peritoneal defense organ. Its main superpower is its immunogenic and fibrotic response. When there's inflammation or infection, it mobilizes. It forms fibrin adhesions, sticky connections at the site, effectively walling off infections, preventing widespread peritonitis. Life-saving. It responds to foreign stimuli by expanding its tissue, expressing factors that attract immune cells, chemotactic, promote inflammation, and help clotting, hemostatic. It basically builds a bridge to the problem area, allowing immune cells and repair factors to get there. A natural first responder.
Can surgeons use this ability?
Absolutely. The Graham patch repair for a perforated ulcer uses a piece of omentum to seal the hole, leverages its natural healing power to improve leak rates, like the body's own smart Band-Aid.
More than just defense, though. Metabolic role.
Yes, significant metabolic involvement. Increased omental visceral fat is an independent risk factor for insulin resistance and high triglycerides, possibly linked to visceral inflammation and obesity. Plus, it actively secretes adipokines, cell-signaling molecules from fat tissue. These act like messengers, affecting metabolic health throughout the body. So, yeah, active metabolic and immune organ, not just a fatty apron.
So if the omentum is our protector and player, what happens when it has problems?
Like any organ, it can suffer its own disorders, sometimes mimicking other issues. Omental infarction is one. Rare cause of acute abdominal pain due to compromised blood supply to part of the omentum. It dies off, can be primary, rare, maybe torsion thrombosis, more in males obese, or secondary, more common due to hernias, tumors, adhesions cutting off blood supply. Challenges, it mimics appendicitis, cholecystitis, diverticulitis, hard to diagnose. Exam shows tenderness, maybe a mass. Ultrasound or CT helps. CT might show a characteristic streaking, whirling, fatty pattern, often diagnosed during surgery. Conservative treatment possible, but risks abscess adhesions. So laparoscopic exploration and resection of the infarcted part is usually preferred. Quick symptom resolution.
What about cysts?
Omental cysts, rare, related to mesenteric cysts, thought to form from lymphatic issues, degeneration, or inclusion, usually single chamber, lined with columnar cells, presentation, vague pain, nausea, vomiting, can cause torsion, infarction, often incidental finding on imaging. Exam might find a mass. CT ultrasound show a well-defined fluid-filled cyst, usually no solid bits, very small risk of malignancy. Treatment is usually resection, especially if symptomatic, open or laparoscopic. Conservative drainage has high recurrence.
And tumors of the omentum.
Most omental neoplasms are metastatic spread from elsewhere. Ovarian cancer is most common, but also GI tract, melanoma, endometrial, kidney. Primary tumors are exceedingly rare. Benign, lipomas, myxomas, desmoids. Malignant primaries are super rare. One type described extragastrointestinal stromal tumors, which is esophagists, share genetic phenotypic similarities with regular GESTs, Sheik, PDGFRA mutations. Median age 65, equal gender split in one review. Other rare primary malignancies exist too.
Okay, moving on. The mesentery, it's not just letting organs float, it connects them. Tell us about this unifying structure.
Exactly. The mesentery is fundamental, now recognized as a continuous organ system. It suspends and fixes the bowel to the posterior abdominal wall, but it's more than an anchor. It houses and conduits all the vital arterial, venous, nervous, and lymphatic structures connecting the hollow viscera, like intestines, to the body. A living scaffold, embryologically, derived from mesoderm, the dorsal mesentery. Understanding has evolved from complex sliding regression to a simpler contiguous model. Initial step, suspension from vascular connections. Then, as intestine mesentery elongate, they undergo that amazing 270-degree counterclockwise rotation, temporarily leaving the abdomen. That rotation sounds crucial. Absolutely critical. Then, re-entry. Duodenum and ascending-descending colon flatten against the back wall, becoming fixed. This creates the white line of Tolt, that of a vascular fascial plane along the side of the ascending-descending colon. Important surgical landmark, relatively bloodless. Crucially, the small intestine mesentery, transverse colon mesentery, and sigmoid mesentery remain mobile. Essential for function. Peristalsis, accommodating contents, but also a potential source of problems.
So, if that 270-degree rotation goes wrong, what happens?
This is where embryology is clinically vital. Defects in rotation fixation lead to intestinal malrotation. Consequence: intestine mesentery, just suspended from vessels, not properly fixed. Highly susceptible to intestinal volvules twisting. Cuts off blood supply. Surgical emergency. Also, these defects can create routes for internal hernias, periduodenal mesocolic areas, can cause acute or chronic obstruction, pediatric or adult. Incomplete attachment predisposes to volvulus. Cecal attachments can degrade, causing laxity, twisting. Sigmoid mesentery can enlarge, leading to sigmoid volvulus, rarely other colon areas too. That initial developmental dance is so key.
What about sclerosing mesenteritis? Sounds like a stiffening. Causes? Implications.
Sclerosing mesenteritis. Rare, idiopathic, unknown cause disorder. Inflammation and fibrosis, stiffening, scarring of the mesentery, can affect the hollow organs it holds and the vessels running through it. Spectrum. Localized form, mesenteric lipodystrophy, or diffuse mesenteric paniculitis. Etiology unknown but linked to prior abdominal surgery, autoimmune disease, perineoplastic syndrome, past infections, typhoid, TB, flu, rheumatic fever, vascular insult. Demographics, most common in white patients, 50, 70 years old. Rare in kids. Some studies show male predilection.
How does it present clinically?
Often nonspecific. Abdominal pain most common. Nausea, vomiting, weight loss, anorexia, altered bowel habits. Chronic or acute. Exam, tenderness, distension. Up to 50% have a palpable mass, often transmits aortic pulsations. CT with IV contrast helps most. Shows a soft tissue mass, denser than normal mesenteric fat. Distinguishing features from tumor might include tumor pseudocapsule, hyperdensone around mass, or fat ring sign, preserved fat near vessels within the fibrosis. Lesions can be calcified, but pathologic confirmation via biopsy, laparoscopic or open, is required to confirm and rule out malignancy.
Treatment, surgery.
Complex, minimal surgical role usually. Many improve medically or spontaneously. Medical options. Steroids, mainstay. Hormones, colchicine, thalidomide, cyclophosphamide. Surgery reserved for complications. Bowel ischemia might need resection, often incomplete due to extent. Obstructive symptoms might need intestinal bypass. Aggressive surgery for the fibrosis itself isn't usually indicated.
Are mesenteric cysts similar to omental ones?
Share some pathogenesis, offer lymphatic disruption but distinct. Mesenteric cysts are rare benign disorders, 1 in 27K to 1 in 250K admissions. Pathogenesis. Lymphatic disruption, trauma, obstruction, congenital malformation, like a drainage problem, usually unilocular, can be multiloculated, lined with columnar epithelial cells. Presentation varies. Incidental finding, acute pain from rupture or torsion, chronic nonspecific symptoms, pain, discomfort, anorexia, distension, nausea, vomiting, altered bowel habits, from compression, up to 45% incidental.
Any specific signs?
Palpable mass in up to 60%. Classic. Telot's sign, mass mobile only laterally, side to side, not up down. Contrast with freely mobile omental cysts. Diagnosis via CT ultrasound, fluid-filled, no solid bits usually. Can be hard to differentiate from solid tumors sometimes. Mesenteric cystic lymphangioma looks like numerous cysts. Malignancy risk, up to 3% contain malignancy, mostly sarcomas. One series reported 19%. Solid components raise suspicion. Treatment is mostly surgical. Marsupialization aspiration discouraged, high recurrence, recommended. Enucleation for benign, resection with clear margins for malignant. May require bulb viscera resection if vessels involved, laparoscopic or open approach.
And actual primary tumors of the mesentery.
Primary mesenteric tumors are rare, diverse histology. Benign, desmoids, lipomas, cystic lymphangiomas. Most common malignant is lymphoma. Imaging shows bulky adenopathy, usually surrounding but not obstructing structures. Critically, lymphoma should not be resected. Operative biopsy for diagnosis is needed to guide chemoradiation. Other malignant tumors. GIS, carcinoids, liposarcoma, leiomyosarcoma, malignant fibrous, histiocytomas, etc. Treatment usually wide resection, but proximity to vital mesenteric vessels can make resection unfeasible or require removing large bowel sections, complex surgery.
Okay, last major area, the retroperitoneum, the hidden depths behind the main cavity. What is this mysterious area? What's in there?
Indeed, a unique and often overlooked space, but critical. The retroperitoneum is the area behind the peritoneum lining. Think of the abdomen as a room. Peritoneum is wallpaper. Retroperitoneum is a space behind it, against the back wall. Boundaries. Peritoneum interiorly. Iliopsoas lumbar muscles posteriorly. Diaphragm superiorly. Levator antemuscles inferiorly. It's divided into 3 spaces. 1. Anterior perirenal space. Anterior to renal fascia, posterior to peritoneum. Contains ascending, descending colon, duodenum, pancreas. 2. Perirenal space. Behind the anterior space. Houses vital structures. Inferior vena cava, aorta, kidneys, adrenal glands. 3. Posterior perirenal space, continuous with peritoneal fat of the anterior abdomen.
Does that structure affect how things grow or spread there?
Yes, an important diagnostic clue is the expansion pattern, because the front boundary, peritoneum, is relatively flexible, and the other margins, rigid, muscles, bones, tumors, hematomas, abscesses, tend to expand anteriorly towards the peritoneal cavity. You might feel a bulge from the front for a problem deep in the back.
Can surgeons access this space minimally invasively?
Yes, the retroperitoneoscopic approach has emerged. Accesses organs like kidneys, adrenals, lymph nodes directly from the back without entering the main peritoneal cavity. Patient position prone or side. Systematic review found similar outcomes, complications, recovery for adrenalectomy compared to laparoscopic, but shorter hospital stay with retroperitoneoscopic, likely due to less pain. Mostly retrospective studies, though. More randomized trials needed for definitive guidance.
If it's so hidden, are infections there particularly dangerous or hard to spot? Seems like they could brew undetected.
That's the issue. Why are they so insidious? You're right. The hidden nature makes retroperitoneal infections challenging to diagnose, potentially dangerous. Can stem from primary blood spread, hematogenous, or secondary infection from retroperitoneal nearby organs perforating or inflaming into the space. Examples: perforated retrocecal appendix, diverticulitis, contain perforated duodenal ulcer, iatrogenic GI perforation, pancreatitis.
How do they present?
Can be subtle, non-specific, back, flank, groin pain, fevers, chills. Can progress to fulminant sepsis. Abscesses can get very large due to the space. Exam might show redness, erythema of umbilicus-like, but often no external signs.
Diagnosis and treatment?
Diagnosis usually easy on CT scan with IV contrast, shows collection, localization. Treatment: source control, treat underlying cause. Drainage of collections, IV antibiotics. Image-guided drainage preferred, but might fail if multiloculated or inaccessible, then operative drainage needed. Delayed recognition diagnosis and insufficient drainage lead to high morbidity and mortality, up to 25% mortality for retroperitoneal abscess. Rare but fatal. necrotizing fasciitis of the retroperitoneum, extremely high mortality, very serious space.
Wow. Okay, last condition here, retroperitoneal fibrosis. Sounds like stiffening and constricting. What is it?
You've got it. Retroperitoneal fibrosis, RPF, is rare, complex, chronic inflammation, and dense fibrous tissue formation in the retroperitoneum, often part of chronic periodontitis, affecting tissue near aorta. Progression. Fibrosis gradually expands. Encasing structures, ureters, IVC, aorta, mesenteric vessels, nerves can impair function significantly. Bilateral involvement in up to 70%.
What causes it?
Either idiopathic or secondary. Idiopathic, IRPF, is 70%, thought to be immune-mediated. Theories. Reaction to atherosclerosis, autoimmune cytokine deposition, can be part of IgG4-related disease, associated with HLA-DRB103 allele linked to autoimmune diseases. Secondary causes are numerous: aortic aneurysms, pancreatitis, certain drugs, ergot derivative beta blockers, hydralazine, methyl-dopa, malignancies, lymphoma, carcinoid, sarcomas, colorectal, breast, infections, TB, radiation, hematoma, surgery, asbestos, tobacco. Complex web. Incidence idiopathic is low, 1.3 per 108 year. Usually 4th, 6th decades, 30-60. Maybe 2.1 male predominance in some studies.
Presentation, often subtle.
Nonspecific, making early diagnosis tough. Most diagnosed after ureteral obstruction. Symptoms: dull acute back flank pain, anorexia, weight loss, nausea, vomiting, fever, malaise, decreased urine output if ureter is fibrotic, signs: hypertension, renal artery impingement, lower extremity edema, diminished pulses, vessel compression, new hydrocele varicocele,
Glad to help.
nonspecific, elevated butyrate if renal obstruction, elevated ESR and CRP, inflammation markers in most, maybe elevated ANA, autoimmune link.
Imaging.
Contrast-enhanced CT is modality of choice. Shows fibrotic tissue, similar density to muscle, often encasing aorta, compressing IVC, MRI if contrasted, contraindicated. Renal US documents ureteral compression hydronephrosis. Abdominal US might show mass. Lower extremity US for DVT.
Need biopsy to confirm?
Yes. Pathologic examination required to confirm diagnosis and rule out malignancy. Lymphoma, sarcoma, desmoid infection can mimic. Biopsy via image guidance for surgery.
Treatment once diagnosed.
Surgical treatment mainly aims to relieve ureteral obstruction, ureterolysis or stenting. Reserved for renal insufficiency patients, surgery has risks. Vascular obstructions might need endovascular stenting. Secondary fibrosis. Treat underlying cause or stop causative drug. Idiopathic RPF. Corticosteroids are mainstay. High-dose prednisone initially, then maintenance taper. Tamoxifen if steroids contraindicated. Response often rapid. Symptoms markers improve in days. Renal function in weeks. Imaging after 1 month if steroids fail. Immunosuppressants. Methotrexate, azathioprine, etc. Outcomes: recurrence 10-30%, but 5-year survival as high as 90% for steroid responders.
Wow, what an incredible journey into the abdominal wall, omentum, mesentery, and retroperitoneum. We've truly unpacked everything, from the delicate dance of embryological development to the complex challenges of hernias and these rare, often hidden diseases. We really went deep on how form meets function, gaining that professional level of insight into not just what, but why things work and what happens when they don't.
Yeah, and what's fascinating here is how this detailed knowledge provides such a robust framework for understanding so many conditions you might encounter in health, medicine, or just everyday life. You now have a comprehensive appreciation for the intricate anatomy, the really clever protective mechanisms, and the sheer precision required in surgical interventions. You've really gained a professional level mastery of this incredible region.
So what does this all mean for you, the listener? Consider this. The next time you feel a twinge in your abdomen or hear about a common surgery, you'll have a new, profound appreciation. You'll know about the 9 layers of protection, the policemen of the abdomen, the vital connections of the mesentery, and the hidden complexities of the retroperitoneum. How might this deep dive into foundational anatomy change the way you perceive the human body's resilience and vulnerability, knowing the incredible details of what lies beneath your very skin? We hope you found this deep dive as enlightening as we did. If you have more stacks of sources you want us to unravel, send them our way. Until next time, keep exploring, keep learning, and keep getting well informed.